There are no echoes. Let's see if our IT people can confirm that there are no echoes. I am Dr. Rizin Kusop, the Secretary of APS. Welcome to our free live streaming webinar brought to you by Association of Private Practitioners Sabah, APS. During the session, as usual, if you have questions, please write them down at the comment section of the YouTube platform, and then the speaker will address it toward the end of the session. Please don't wait at the end of the session to write the question. Once the question pop up in your head, please write them down so that you have time. I mean, we have time. The speaker will have time to address them at the end. Our speaker this evening is Dr. Sivaharan Thambapillay. Dr. Sivaharan is a consultant specialist in trauma and orthopedic and currently working in Jesselton Medical Center, Kota Kinabalu. He graduated from Sheffield School of Medicine, England in 1998 and subsequently earned his FRCS in 2014. He has extensive experience working in various hospitals in UK before started working in Malaysia, and now he is in JMC Kota Kinabalu, Sabah. He has been involved in numerous postgraduate works, audits, and academic publication related to his field of specialty, of course. The topic he'll be delivering today is repetitive stress injuries, the scourge of handheld gadget. Ladies and gentlemen, Dr. Sivaharan Thambapillay.
Thank you very much, Dr. Rizin. Good evening, ladies and gentlemen. My name is Siva. I'm the orthopedic consultant at Jesselton Medical Center. A very good evening to all of you, and thank you for attending this session, which I am going to talk about repetitive stress or strain injury. And nowadays, we're using a lot of handheld devices, and it seems to be a big public health problem at this their age. Before we proceed, I would like to thank APPS for kindly inviting me to give this talk this evening. Without further ado, I'm going to start with the session. As Dr. Rizin said, please, if you have any questions, please do write them down on the platform provided, and I would be happy to answer them at the end of this talk. So, what is repetitive stress injury? Let's talk about what we do from day to day. If you look at this particular slide, you can see there's an evolution of the mobile phones that has happened over the last 20, 30 years. To the far left, you can see those brick-sized mobile phones that only a few of us could afford in those days. It was a luxury. And then towards the 90s, most of us could afford a mobile phone, but it was quite funny how the size of the mobile phones started decreasing in size, and that was the trend, so that it could fit nicely into your pocket. As time went by, mobile phone became a necessity for most of us, whereby we could communicate, we could do all our internet searching, including buying things on Lazada and Shopee. So we needed something bigger, something stylish that could fit at least our coat pockets or even for the ladies, the handbags. And we have numerous numbers of mobile phones available. What about gamers? They have got a huge selection of what they want. I think, one of my consultants used to say when I was a trainee that in the world of technology, neither do you want to be at the trailing edge or the leading edge. So I'd be quite happy to be right in the middle and enjoying technology. And I presume all of us want to have that comfort for entertainment. And there are various types of handheld gaming consoles that are available today. And as you know, in China, recently, the government has extended sort of a curfew. It's a 1 to 3 hour ban or 1 to 3 hour limit on children playing gaming consoles, and there's a good reason for that as well. Now, I'm afraid the image is not clear, but it's just if you're a gamer, you'll have a six-pack on your thumb, which shows that you're very well trained in your gaming console. Now, the topic that I'm going to speak about today, I'm just going to give you a bit of a history, anatomy, physiology, what we mean by repetitive stress injury, the management and preventive measures. Now, I don't know whether you know this gentleman. He's Professor Bernardino Ramazzini, who was an Italian professor of medicine in University of Modena in Italy. He has been quoted as a father of occupational medicine because he had written this book about disease of workers. And he was the one who mainly added to our armamentarium of questions when our patients come to our clinic to see us. Please do ask them, what is your occupation? Because that is very important for ailments that they come, which may be related to musculoskeletal or neurovascular disorders. He was the first person to describe RSI, or repetitive strain injury, in more than 20 categories of industrial workers in Italy. At that stage, it was mainly musicians and clerks. Now, this was before the Industrial Revolution, so we have had a big problems of RSI long before the Industrial Revolution began. So RSI initially started as a big theme, as an occupational hazard. Started with people who are mainly typists, who are typing many hours a day. And then now on the right-hand screen, you can see that, people who are working on a production line in factories. They work for hours on end, and they do the same repetitive movements without much breaks. Because at the end of the day, productivity is very important for the company, which equates good profits. But at the end of the day, the patients or the employees are the ones who suffer with the RSI. And at present, in the US and the Western world, RSI is a big factor in litigation, whereby people get time off work having their health care compromised, and hence there's a lot of litigation going on. So it is a big topic among the Western countries. So first of all, back to basics. I'm going to talk a bit about anatomy and physiology of the tendons. Now, I'm going to talk about it mainly because RSI mainly affect our upper limbs, which is going to be our hands, our forearm, elbows, shoulders, and it extends up to the neck. So let's go back to basics. What are tendons? Tendons are transducers of force from muscle to bone. Now, they are the ones that act as a lever and increases efficiency of action of muscle on your locomotion and your movement. So the anatomy of the hand, if you look at the back of your hand, you can see there's a thick fibrous tissue called the extensor retinaculum. And more importantly, you have a network of tendons, which are called the extensor tendons, that are nicely wrapped under this extensor retinaculum that moves your thumb and your fingers. Now, as you can see, if they glide nicely, if they have good space, they're always going to work well in harmony. But once you start overstretching one of them, that's when trouble begins. So this is the palm of your hand, and these are your flexor tendons. That's your thumb, that's your little finger. And what this doesn't have is your flexor retinaculum, which has been cut, and you've got a median nerve that travels under the flexor retinaculum, and this can also cause problems like carpal tunnel. Going to your forearm, as you can see, if you are quite a muscular person, you can see each muscle quite nicely. And what I need to bring to your attention is that this is on the volar surface, which is where your biceps tendon comes in. And on the medial side, you got what's called the common flexor tendon origin. And that's where when they have a lot of inflammation that causes the golfer's elbow. And equally on the lateral side, where all your extensor muscles originate from, if there's a lot of inflammation, causes what we call tennis elbow. Now, you don't need to be playing golf or tennis in order to get these problems, but it is a common misnomer, really. Now, going to basic science, it's a bit of a boring subject, but I think it's important to illustrate why tendons fail. Now, if you look at this particular graph, on the y-axis, you've got the load. That's the amount of load that we apply on a tendon at any one time. And at the bottom is the elongation, or what we call the strain. Now, especially in tendons, this is the engineering terminology. In tendons, when they are at rest, they are all there's crimping of the tendons. So when you apply a particular force on them, they start unfurling, and that's called the toe region. So the initial bit is quite easy. Following that, you have to apply some force, and this is what we call the linear region or the elastic region. So at this point, you can pull it up to that point, and when you release the force, the tendon will go back to its normal shape. And then once it reaches a point of no return, that's what we call the failure region, where the tendon will tend to start breaking and then it just ruptures. So that is in simple graph showing the biomechanics of the tendon. Now, slightly, this is a different graph, but stress is same thing. It's the load, and strain is the elongation. And you can see with the toe region, you can see that there's a lot of crimping of the collagen fibrils. And then the linear region is when you pull on the tendon, it straightens out. And then when it fails, that's when you get the rupture. Now, the next slide will show you, in terms of engineering terminology, they have done a lot of study on materials as well as tendons. And what we call the endurance or fatigue limit is they apply particular stress to a particular material, and the usual arbitrary figure that they come is 10 million cycles. At 10 million cycles, this is the stress or the load that will break the particular material. And if you keep doing any work at the load that is below this graph, technically the material should not break. But as you can see, over a period of time, the stress that's required to break the material reduces, which means that this is what happens over a period of time. And there are other factors as well, such as deconditioning, age. I'm not being ageist here, but unfortunately, that's what happens with us as we get older. So what does that mean in terms of repetitive strain injury? So in repetitive strain injury, your first 3%, 3 to 4% is within physiological range. And then the minute you go between 4 and 8%, that's when you fall into the area of overuse injury, whereby the tendons start slipping over each other, and there will be some micro tears of the collagen links. And this is what causes micro tears, inflammation, swelling, pain, and reduced function. And then when you reach that 8% elongation and above, that's when tendon rupture occurs. But in terms of this repetitive strain injury, we are not going into tendon rupture, we're just going into the overuse injury. That's the topic that we're talking about today. So this is a big flow chart about what happens in overuse tendinopathy. There are intrinsic factors, which is, as we all get a bit older, our body weight, our nutrition status, gender. They say that ladies are a bit more vulnerable. Anatomical variations, as we all know, our hands are not the same size, and mobile phones are not custom made to match our hands and our digits. If we have joint laxity, which means that if we have hypermobile joints, then we can do more in terms of typing and all that. However, that will put our joints and our tendons at further risk of injury. Extrinsic factors like occupation, the type of job that you do, what are the recreational habits that you have, Are you a gamer? Do you spend a lot of time on your mobile phone? So all this, if there's overuse injury, you'll get micro tears within the tendon, and this starts the process of inflammation, and that in itself causes swelling and pain, which is tendinitis. And as you can see, it leads to your clear definition of what inflammation is all about, which is swelling, pain, uh, erythema, loss of function. And if you don't deal with it, the problem is this will become a recurrent problem, and it will lead to degenerative tendinosis, and it become a chronic problem. So what exactly is repetitive strain or stress injury? It is a spectrum, actually. It's not a diagnosis, but it is a spectrum of musculoskeletal and neurovascular disorders. It's also known otherwise of overuse syndrome or cumulative trauma disorder. Now, this condition occurs due to repetitive, forceful, or awkward hand movements for prolonged periods of time. Now, eventually, it damages the muscles, the tendons, and nerves of the neck, shoulder, forearm, and hand. So, what does it mean to the person who's suffering? They will cause pain, weakness, numbness, or impairment of motor control of the upper limbs or neck. Now, in real terms, for the patient, it's a loss of function, a lot of pain, but to the companies, it costs billions of dollars every year, not only in healthcare costs, but in time off work and lost productivity, as well as litigation. Now, what are the risk factors? These are the risk factors that they looked at people who have RSI, who work at the computer terminal for a prolonged period of time. Temporal, in terms of time, they have lack of rest breaks and recovery. So there's a lot of intensive work base. There's a lot of task repetition. Environmental ergonomics. So they have incompatible work surface height, inadequate chair support. Biomechanical, excess force that they apply at their hands when they are typing on the keyboard. Localized compression, tension and friction of the tendons. How about their physical or anthropometric features of the patients? It all depends on what your anatomy of your hands, your fingers look like. As I said about ligament laxity in terms of hypermobility joint. Deconditioning and age, unfortunately, that is an intrinsic factor that we can't change much. Postural, mainly non-neutral postures of the head, neck, shoulder, elbow, and hand and wrist. These are definitely big factors in causing RSI. Lastly, behavioral. I mean, we have people who are type A personality, they want the job to get done, irrespective of whether their body says no because they are hurting. They have unrealistic expectations, and people who have got psychosocial job stress. So you have to look at a multitude of factors when it involves people with RSI, not just looking at their hand and saying, yep, this is what you have, and this is what you have to do. So what about handheld gadgets? It's very, as I said at the beginning of the slide, every one of us have got a handphone at some point. I presume even children these days have got a handphone. If not a handphone, they at least have got a tablet. So it is not uncommon for them to be spending a lot of time on these handheld devices now. It's mainly used for communication and entertainment purposes. Now they have access to media, internet access, and gaming. They engage a substantial period of their time on these devices. About 9 years ago, BBC reported that on a daily basis, there are 19 billion messages being sent on chat apps or social medias, and SMS alone was 17.6 billion. And 3 years ago in the US, there was a study that said adults, we're not talking about children, but adults spend an average of 3.5 hours on mobile devices daily. By now, the mobile devices that we use will have surpassed TV as the medium attracting most minutes in the US. And there have been numerous studies that shows sorry.
There's no audio or what?
Can you hear me?
Is your mic on? Where is that?
Can I? Sorry about that. There was a problem with the sound system.
Nobody's complaining though.
Can I start? Yeah, okay. So there have been studies that have shown among university students there's a high prevalence of this new phenomenon called nomophobia, no mobile phone phobia. So it's no longer an accessory. It's something that is surgically stitched to us these days. We cannot leave the house without a mobile phone. Otherwise, we'll be completely lost these days. Now, what has the COVID-19 pandemic done? Is that it has mainly revolutionized our way of living. There's a new terminology called social distancing, where it's a combination of physical distancing, but we still connect to each other. Let it be our friends, our family, especially at this difficult time in our lives, we have people who live so far apart from their spouses, their children, their parents, and they need to be connected. So mobile phones have become a very important tool for us to engage, to preserve our mental health, really, for our own mental health well-being. And more importantly, we need our smartphone for our My Sujatra check-in. Otherwise, I would not have been able to check in today to give this talk without my mobile phone. So I think it has become compulsory for you to get about with your smartphone these days. So, as William Blake put it aptly, a road of access leads to the palace of wisdom. So, there's a lot of ways you can interpret that particular quote, but what I'm trying to say is moderation is what is important when it comes to mobile or gaming. So, these are the common RSI related conditions. I'm breaking them into two categories. One is musculoskeletal and the other one neurovascular. Musculoskeletal disorders that we commonly find with these group of patients one is trigger finger or trigger thumb, tenosynovitis or wrist extensors, de Quervain's tenosynovitis, myofascial pain of the intrinsic hand muscles, tennis elbow, shoulder tendinitis and impingement symptoms, cervical spondylosis. What about neurovascular disorders? Carpal tunnel syndrome, which most of us are familiar with, Raynaud's phenomenon, cubital tunnel syndrome, which I'll come to, thoracic outlet syndrome, and cervical radiculopathy syndrome. Now, these are quite a common manifestation of people with RSI these days. And only the other day, I saw a patient who came to me having a trigger thumb on one side and a carpal tunnel syndrome on the other side. And the poor lady works as a typist, which she has for the last 30 years. But I don't think it's helped by the fact they also need their mobile phones to carry on with their social life. So I think this is the curse of the current technology that we have. So I'd just like to bring you to attention to a few of the common disorders that I or myself as an orthopedic surgeon frequently see in our clinics. And I presume as GPs, you'll be seeing a lot more of them. And just a quick note on each disorder, the common disorders. So this is the texting thumb or the trigger thumb. As you can see, on the right-hand side of the screen, you can see this is a large phone. So they need to rest the phone on their index fingers, and it only allows their thumb to do most of the typing. So hence, they end up having some problems with their thumb. And one of the problems that they have is what we call a trigger thumb, whereby the flexor tendon has to glide through this pulley. And every time it glides through the pulley, there's going to be some sort of a friction, and they develop this inflammatory nodule, and hence they'll start having triggering of the thumb. It's just as much as the easiest example I give to my patients is when you're trying to sew and you're trying to get a needle and get your thread to go through the eye of the needle. If it's a fresh thread, you can thread it quite nicely, but once the thread starts fraying at the edge, when you try to put it through the eye of the needle, it starts clumping up and stops going through the eye of the needle. And that's what happens in this condition with the trigger finger or trigger thumb. Now, originally this was called the BlackBerry thumb because this was a lot of people who were using BlackBerry on a frequent basis developed this particular pathology. The other one is Quervain Sinovitis, which is actually a pathology involving two extensor tendons in the first dorsal compartment, which is actually here, but these tendons attach to the base of the thumb. So hence, you can imagine when they move their thumb up and down to do their typing, there's a lot of friction of these tendons through these thick fibers, and hence they end up having inflammation. And this used to be a common feature that we used to see in young mothers who had babies or toddlers because they used to carry them quite often and they used to develop Quervains. And these conditions tend to resolve by itself once they stop lifting the children. Now we are seeing this re-emerge as a problem among frequent mobile users. Carpal tunnel syndrome. I assume or presume that everyone knows about this. This is a nice slide from our own Ministry of Health giving some advice about carpal tunnel syndrome. And you can see that you have someone using a laptop and is already using a wrist splint to help with their symptoms. Okay, so it is a very common problem. The nerve, which is a median nerve, runs under this flexor retinaculum here, and because of the frequent typing and the position of the hand, which is in flexion, it tends to compress this nerve, and this in turn causes inflammation of the nerve, and hence they have problems of pain and pins or needles in the fingers, and this reduces their work or functional capacity. The other thing I mentioned about is the ulnar nerve can be compressed at the wrist, which is what we call an ulnar tunnel syndrome, or at the elbow. Now this happens a lot when we tend to lean on our elbow quite frequently. Sometimes we call it the funny elbow syndrome. And when we sit at the computer for too long and we bring our head forward and our torso forward, sometimes these nerves can get trapped within this particular area under the clavicle, which is called the thoracic outlet syndrome. So these are a manifestation of the neurovascular disorders that can come with this. Now, this is quite a nice slide that illustrates that the ideal posture for us to be when we use our handheld device should be us sort of being very straight, or what we call a neutral posture. As you start bending your head or neck forward, when you're at 60 degrees of bending your head forward, you have a load of 27 kilos that's constantly being applied on your neck. Now, in simple terms, think of a crane which has got a heavy boulder at the front. And the heavier it gets, the muscles on the back of your neck tends to work harder to keep the posture upright. Otherwise, you will fall forwards. And think about the poor muscles that is holding 30 kilos of your neck whilst you're busy on your hand phone or on your gaming device. We tend to get lost in our hand phone for hours at times. So we have to also think what our poor muscles are doing. Now, the cell phone elbow, as I said, you can get cubital tunnel syndrome or tennis elbow, trigger thumb, and then you have got problems in terms of extensor tendonitis, myofascial pain because of repetitive use of your muscles around your hand and fingers. This is a very funny article that I read. This is from Australia. It's a Daily Mail that says that it's called a texting neck because children and teenagers spend a lot of time on their mobile phones because mobile phones has become part of their social identity now. They are on Instagram, Twitter, Facebook. A lot of the times they want to be the hip culture. So they spend a lot of time on the mobile phones. And you remember the anatomy, our neck is supposed to be lordotic, which means that there's supposed to be a slight curve anteriorly. But in these people who spend a lot of time, you can see there's a reversal of the lordosis. And this is not good for our neck. You can imagine what it does when it starts going to reversal. It can cause problems in terms of the biomechanics, can cause problems in terms of your discs, and eventually it will lead in terms of impingement of the nerves that runs through your spinal canal, which causes radiculopathy symptoms. So these are main problems that occurs. The treatment, as I said, this is mainly a public health issue now. You have to identify the problem at the acute stage and try to treat it at the acute stage so it does not become a chronic problem. So first and foremost, identify what is causing your problem and try to stop, if not modify the activities. So early recognition is critical. As you can see, I'm an orthopedic surgeon. If they come to me, the first advice I give them is RISE, which is rest them. Ideally, avoid using the handphones or limit the amount of hours. So you have to have your screen-free time. Apply ice to the areas where it hurts. Now I put compression. In my line of work for the hands, the thumb, we tend to apply what we call a splint, a wrist splint or a thumb wrist splint, which tends to keep the position of the wrist and the thumb in neutral and reduces the inflammation and helps with the healing and elevation. If the pain is quite severe, you need to give them analgesia. Let it be topical, like a cream. Non-steroidal anti-inflammatory creams are quite good, or even non-steroidal anti-inflammatory drugs like ibuprofen. Physiotherapy and occupational therapy is extremely important for this group of patients because they'll teach them, sort of ergonomics, teach them what type of exercises they need to do in between them using the handheld devices so as to reduce the overuse injury. And more importantly, ergonomics is very important. What is ergonomics? As I said, in the acute treatment, referral to physiotherapy is very important. So you have to think about alternative strategies. Using hands-free features on the phone, if you can. Nowadays, we have stylus pens, so you can use them instead of typing messages. It's very important we have to have mobile free time, especially gamers. They also need to have a lot of gaming time. Now, talking about cubital tunnel syndrome, as I said, it's a problem with the nerve, ulnar nerve. It can cause motor weakness of your intra-ossei muscles, which is what we call the web spaces. And it can cause pain and paresthesia in the ulnar border, which is the outer border of your hand and your little finger. Now, ergonomics is very important. If you spend a lot of time at the desk, make sure that you have some elbow pad so that you protect the elbow. And when you go to bed at night, rather than keeping your elbow really flexed, you can use some kind of a splint that keeps your elbow in mild or slight flexion so that you don't apply too much pressure on the ulnar nerve. Professor Ramazzini says far better to prevent than cure. So what prevention do we talk about? As I said, ergonomics is very important. That is adapting or changing our environment to suit our body. So what we need is the most important thing that we have to take home from this talk today is neutral postures. That is what our body is used to. The minute you start putting them in awkward positions, our body will start complaining in one way or the other. So this is what I tell all my patients who have neck pain. Make sure that your computer, the monitor is always at that level of your eye. And when you're set, make sure you're set in a nice chair that makes you sit straight. And your feet should always be firmly planted on the floor. It's always good to invest in a nice chair that you can adjust the height of the chair because you can never adjust the height of your table. And you find that the chair is a bit too high, put a little platform so that your foot is flat. Make sure that your elbow is always at right angles and your hand and wrist are virtually straight over the computer. So you need some good padding for the computer keyboards or ergonomic keyboards are the key these days. What about gaming chairs? Now, I think that's a great thing. It's expensive, but it saves a lot of hassle. I think, as they always say, necessity is a mother of all inventions. As you know, gamers, they love to spend so much time. So the gaming industry have to provide some form of mechanism so that their clientele can carry on gaming and buying more of the products. So they come up with this gaming chair, which is on average about 600 US dollars. But these are pretty good actually for people who spend a lot of time at their work, tops, especially accountants, people who work at the computer. Nowadays, it's become even more common because teachers, students, pupils, they're all doing online work from home, so they spend hours on end in front of the computers. So I'm not saying that all of you all should go and buy a gaming chair for your son or your daughter or for yourself, but think about it, whether it's worth it for what symptoms you have. So what does a gaming chair provide? It's got this high paddedness with a reclining backrest. They've got a neck pillow, they've got a lumbar pillow, and you've got arm rests that allows your arm to be at neutral compared to your office chair, which is pretty decent. But with the office chairs, you have to have frequent breaks. Now, I've always told my patients, just think that I'm not advising you to become a smoker, but just think of smokers. They always have their cigarette breaks. So in a way, every hour you should try to time yourself so that you get breaks and go away and do some stretching exercises for your upper limbs and your neck so that, give 5-10 minutes every hour so that, sort of don't put yourself at risk of developing RSI. So what about the future? This is what we call exoskeletons. Some of you might have heard about them. These are things that make us superhuman. They were initially designed for military to make them lift things that are super heavy. Basically, exoskeleton is a bit like, Iron Man. So basically, you're using all these devices to make you do wonders and reducing your risk of RSI, especially people who work on the production line in factories. And you can see the OSI injury and illness incidence rates in the US over the last 20 to 30 years has been decreasing for two reasons. One is because of people accepting that RSI is a major problem. So it is the obligation of the employers to make sure that all their staff are protected. They have got ergonomic engineers to make sure that whatever work that their employees are performing are not going to put them at risk of RSI. So this is the next stage of what we will be doing. Now that's all I'm afraid I have to talk about today. Thank you very much for spending 40 minutes. And if there are any questions, I'll be happy to answer them at this stage. Thank you.
Thank you very much, Dr. Siva, for that very informative and interesting presentation.
Thank you.
I certainly learned a lot. We don't have any question posted in the YouTube platform at the moment, but we'll wait for a few minutes. In the meantime, I would like to discuss a few points.
Yes.
We as a GP, of course, we frequently see all these neck problems and thumbs, wrist, and elbow problems. Um, Based on what we have heard and listened from you, would it be fair to assume that they all should be assumed to be related to handheld gadgets before you start looking for any other cause in GP setting? Or what would you say?
Thank you. That is a very good and pertinent question. We have to accept the fact that mobile phone is part of our life now. Now, it's very important for us to know what the occupation is, because some of them spend a lot of time at the computers. And, I really feel sorry for people who work in these mobile or, phone call centers. They spend a lot of time in front of computers and their phones and all that. So I think it's very important when they come we have to spend the extra 5 minutes asking about the occupation, asking about what exactly do they do. What about in terms of, do they use a lot of hand phones? Roughly ask them, do they spend a lot of time on their mobile phones? Are they gamers? And then try to elicit if they have neck problems. How long have they had it? And when did it start? And ask them themselves, do you think, just if you just turn around and ask them, what makes you think that you have got this problem? What do you think is the root cause? Sometimes patients, they know,
True.
So I think rather than us telling them you shouldn't be using this, you shouldn't be using that, I think let patients take responsibility for their own health and their social lifestyle. And I think in a nice way, just tell them that I've also got a handphone. I understand where you come from, but I think at the end of the day, it does cause problems, and if it becomes unchecked, it can cause future problems, and it may become chronic. So I think it's more an educational consultation that you have with them, an educational informative consultation that you have with them, because it's very, very difficult to separate mobile phone from what they are doing at work.
That's right.
Okay.
Thank you, Dr. Siva. I guess my next question is, when will us as a GP need your help as a specialist? When do we refer? I suppose that question. Do they end up needing surgery at some stage?
That is thank you for that question, because now technically general practitioners are the primary care physicians. So I would strongly recommend that all patients see primary care physicians in the first, because you're like the family GPs. So I think you will have a better history of what is happening around, and you can follow them up on a frequent basis. Now, as I've stated initially, the acute treatment is quite straightforward: rest, icing, modification of their lifestyle, and then review them in a couple of weeks, 2 weeks, and see how they're getting on. I think physio is also equally important for these people. Give them a few weeks and review them. If you feel that things are improving, then I think you should pat them on their back and say, well done. You're doing all the right things. Please carry on with what you're doing. But if you feel that they're not getting any better, then say for trigger thumb. Usually, if it's treated very early on with the exercises, with some wax therapy and things, most of them get better. But if they continue with that problem, then the next stage would be an injection, which is a corticosteroid injection, which can be done in the outpatient setting. So if the general practitioner is quite happy to do it in their clinic, well and good. If they're not happy, then you could refer them on to us. Even when we see them, surgery is not the first resort when they come and see us. Usually surgery is the last resort. So if they have had an injection by yourself, then we would advise them to continue and see how they do over the next couple of months. If it's still problematic, then we will offer a surgical release. But if they not had the injection, we would do the injection and then see them back. Same thing for carpal tunnel. You see. Now the problem, what you have to accept is some of them, their livelihood sort of depends solely on what they're doing. Hence, the problem is they want to get back to their job. They want to go, earn a living, so they want a quick fix.
Exactly.
And that's where the dilemma comes in. That's when you can give them an injection.
All right. Thank you, Dr. Siva.
Thank you.
There's one question here from Dr. Saijan. Any role of infiltration of LA steroid in chronic condition of analgesic? If analgesic not much help, I guess you just answered that, but you could explain.
Thanks, Dr. Saijan Summit. Yes, definitely there is a role for local anesthetic and steroids injections if simple measures do not work. Now, you have to be very specific about which particular condition we talk about. Number one is, as I said earlier, trigger finger, trigger thumbs, yes. Carpal tunnel, yes. Duke Evans, yes. Tennis elbow, golfer's elbow, yes. But you have to always inform them about the risks. The risks that I would personally would say to my patient, one is there's a small risk of infection. Number two, in areas where the infiltration is going to be quite superficial, there's a risk of fat atrophy, and there will be hypopigmentation of the skin at the site of injection. Usually this happens more in people who had repetitive injections. Number three, you cannot give a full sort of guarantee that the injection is going to take away all or most of their pain. And most importantly, when you inject steroids around tendons, there is a small risk of you weakening the tendons and the tendons can rupture. So these are the side effects that I will also mention to the patient prior to giving them the injection, which I hope answers the second question that you've asked, Dr. Sajan.
Yep, I think that's covered the second question. We don't have any question yet at the moment. So again, thank you, Dr. Siva.
Thank you.
Thank you for all the participants. We will show the QR code now so that you can scan and get your CPD point. At the same time, I want to thank you, our Secretariat, Ms. Melissa and Mr. Adrian, for their assistance. And I would also like to acknowledge our sponsor, Kuala Lumpur International Healthcare Center, Top Biotech, Medinix, and Gribbles. Before we end, I would like to give this opportunity, Dr. Siva, to give one final parting words for all of us GP here in Sabah. Do you have anything else to say, Dr. Siva?
Thank you, Dr. Rizin. Yes, what is important is we are going to see more and more of RSI, whether you're a general practitioner, whether you're a physiotherapist, occupational therapist. I think that, as I said, it is a fairly decent way to treat them if they are identified right at the beginning. If we don't, then the risk of it becoming chronic is going to be an issue. Hence, I think we always have to keep our eyes and ears open to all the new technology that's out there, because these are the things that can make, as I said, there are a lot of things out there that is good, but we only see the ugly side of it further down the line. So keep up your good work to all the general practitioners of Sabah. And you all have been excellent during the COVID-19. And thank you very much for attending this talk this evening. Thank you.
Thank you very much, Dr. Siva. Thank you all. We will see you again in 2 weeks' time.